Hi, my name is Scott Bradley. I'm a clinical instructor here at Stanford University Hospital, and I'm a part of Stanford Emergency Medicine International, and I'm here to talk to you today about acute headache emergencies. Our objectives in this talk are to identify patients who are high risk for medical emergencies that present with acute headache. Headache is an extremely common presentation, and our job is to try to parse out who has a potential emergent medical condition that we need to intervene on. And then we'll use a case presentation to discuss the evaluation and management of a patient with an acute neurologic emergency. Now, as a little bit of background, I just want to let you know that headaches are common. I'm sure you've all experienced one yourself. World Health Organization estimates that between 50% and 75%, half to three-quarters of all adults experience headaches at least once per year. Now, the most common cause of headaches are what we call the primary headaches, headaches that originate from the brain and are benign or non-dangerous. And as you can see, tension headaches, muscular in origin, migraine headaches, and cluster headaches comprise over 50% of these and are largely responsible for the headaches we see even in the emergency department. But I must caution you, while these are benign headaches, they can often present similarly to emergency medical conditions, and also emergency medical conditions can mimic the benign headaches. They can have similar symptoms. So if you think these primary headaches can be severe, they can be the worst headache of your life, they can cause nausea and vomiting, they can cause abnormal vital signs, stiff neck, especially if you have tension headache, it can cause vision changes, or focal neurologic deficits. So it is difficult, but we're here to give you some tools to try to identify who needs further evaluation, who needs to be managed and stabilized, and who can be sent home in a more reasonable fashion and just treated for their pain. So these are the more dangerous aspect of headaches, and this is a very dense list and very extensive, but unfortunately secondary headaches or headaches caused by other processes, the list is quite extensive and makes up the other 50% of the headache causes. But the ones we are most worried about, of course, are infections of the brain and surrounding areas of the head, vascular insults, whether or not bleeding, hemorrhagic strokes or possibly ischemic strokes or blood clots in the brain. Masses can cause headaches, trauma, of course, overproduction of cerebrospinal fluid, toxins, exposures to carbon monoxide, toxic alcohol. The list goes on. And it's important to get a thorough history and physical to try to find out and hone down and target which are the possible causes, but there are many. So let's go to our clinical case at this time. So right now we're going to go with a case of a patient with the worst headache of life. So the case today involves a 67-year-old man, and he's brought in by his family with a severe headache. He reports that it is the worst headache of my life. He reports it as being sudden onset, and at the time that you see the patient, if the patient is triaged in your department, the patient is unable to walk, and he's confused about the events of the day preceding his visit to see you. Now, just to reiterate, we take the emergency medicine approach to this patient where we evaluate, think, and act all at simultaneous times, and we go in iterative processes to try to go back to act, think, and evaluate. So this is the initial evaluation aspect of this patient's presentation, and so we're going to go and see what we see. So the initial assessment, when we look at their level of consciousness, their general appearance, the patient is now roomed. You notice that he is confused, uncomfortable appearing, not wanting to move. He's lying in bed in a darkened room. Okay? And noting his airway, he's speaking without difficulty. He's able to answer your questions. Breathing is normal with clear lungs. Circulation appears intact. It's not a thready pulse. You do know strong bounding pulses, but that can be essentially normal. And what we noticed on initial presentation that the patient is confused, not completely coherent, uncomfortable, and lying in bed in a darkened room, all of which can be potential red flags and potential dangerous signs. Vital signs are taken. Heart rate's normal. Respiratory rate, nice normal 16 beats per minute. Respirations per minute. Blood pressure's quite elevated, 220 over 115. Oxygen saturation and temperature appear to be normal. Look at that blood pressure. That's definitely what we call an abnormal vital sign and may have an element, a role to play in the presentation that we have today. So after our initial assessment, we have a 67-year-old male, acute severe headache, altered mental status, weak, with extremely elevated blood pressure. So is this patient sick? And I think we would all agree that anyone who's confused is sick, and confused with abnormal vital signs with severe headache is certainly sick. So your immediate interventions while you're doing your initial assessment. Here are the options you have in front of you. You've been presented these before. As you've noted, the patient's vital signs, while not being normal, are not necessitating immediate intervention in terms of airway control or CPR, but given this patient's potential unstable presentation, we do want to make sure that they are monitored. We want to make sure they have oxygen, because hypoxia certainly, or transient hypoxia can cause confusion. We want to make sure they have an IV to give medications, and we certainly won't like to check a blood glucose, because altered mental status in any presentation could certainly be a metabolic abnormality with hypoglycemia. So we initially go to those treatments. As you can see, the blood sugar is elevated at 209. However, that is not a dangerous number, but does indicate that something may be going on, or the patient may not be taking appropriate medications if they are diabetic. So moving on, there are additional patient, again, presenting with headache, altered mental status. There is a rapid tool to assess a neurologic function that you can add to the list that we just presented in the previous slide. That tool is called the Glasgow Coma Scale. Now this is initially developed more for traumatic brain injuries, but it definitely has a role to play in medical brain injuries as well. Now, it is a neurologic scale used to assess the severity of the brain injury for medical and trauma patients. It's a 15-point scale, 3 components: eye, verbal, and motor. 15 points is a completely normal exam. 3 is what you'd get if you were deceased with no neurologic function. And then everything between, you have mild, moderate, and severe brain injury. So with this particular patient, while he is in a darkened room, his eyes open spontaneously. You can go over this at your leisure, and we'll get you this list, and I'm sure it's in the reference material, which is a full points of 4. When talking to the patient, it's certainly not incomprehensible sounds. It does not appear to be confused words, but he is confused and not fully oriented to person, place, time, and event. So we would give him 1 off for disorientation. That's 4 on the scale of 1 to 5. Now the motor is a little more complicated, but essentially, if you have a full marks, if you can follow commands, and this patient does, decrease the scale. If you localize to pain or you withdraw to pain, you get lower numbers. And the decorticate and decerebrate portions of this scale involve involuntary movements related to severe brain injury. Patient does not have any of those. He obeys commands. 4, 4, 6, that's a GCS of 14, which, as we just saw on the previous slide, is mild brain injury at best. So it's actually kind of a reassuring number in that it's 14. It's high, but it's certainly not completely normal. So now that you've gone through your initial assessment, you've done your glucose, you've gotten your initial evaluation of airway, you've gotten your GCS, we're now going to re-evaluate to do more thorough, more targeted evaluation based on the patient's history, focused physical examination, developing a differential diagnosis along the way, and we will then go for further actions to try to to treat the patient's symptoms and help mitigate the disease process. So the sample history, just to review: symptoms, allergies, medications, past medical history, last meal, and events. As to the symptoms, patient is 67-year-old male with severe headache and going through our mnemonic OPQR-STU. The onset was roughly 1 hour ago, 1 hour prior to presentation. It was witnessed. He was with his family. He was helping them move heavy boxes. They were moving homes. Headache is, again, severe. The provocation is headache is worse with movement of his neck, and it's worse with light, so he definitely has some photophobia or light sensitivity. Quality, it's a sharp pain, radiates around the head down to the neck. Again, very severe, 10 out of 10 pain. Worst headache of his life. And he said it was a sudden onset in its timing. In addition, in the unifying symptoms, he has the confusion, which we've noticed. He's vomited prior to the arrival, and he's feeling weak, unable to walk. Again, in looking at these symptoms, there's some concerning parts of this sample history that certainly need to be intervened on, or would be considered what we call red flags. In continuing his sample history, allergies, none reported by family. Medications, he is on metformin and lisinopril. Unclear if he's taken those medicines recently. He has a history of hypertension and diabetes. His last meal is unknown. And again, the events around this particular presentation is that it occurred with strenuous physical activity, and the family even notes a near fainting episode after it initially occurred, which are, again, concerning things. We've gone through this headache sample history, but I just want to make sure you know when someone comes to see you and has a history of headache, whether it's emergent or not, it's important to get a targeted, complete headache history, and this does include the timing of the headache, meaning sudden or gradual in onset. Sudden tends to be a little more dangerous than gradual. The character, location, and radiation of the pain, if it involves the neck at all, which would be concerning. Events that occurred at the time of the headache onset, any precipitating factors. Was there trauma involved? Is it associated with activity? Is it associated with other exposures to other sick people? Does the patient have a history of headaches? If they do, of course, another headache doesn't seem that dangerous. If this is a new headache, it's a little bit more concerning. And if there's any past medical conditions or medications, blood thinners that are concerning, past medical history, including immunosuppression, can be concerning. Multiple issues that can help narrow down our diagnosis. And again, of course, associated symptoms. Now we're going to move on to the focused physical examination. And as you might imagine, for headache, a neurological examination is going to be one of the most important things you can do. It will evaluate the level of function of the brain to see if this headache has caused any impairment or damage to the brain itself, or it may indicate if the brain is at risk. The brain's fairly important, so we need to understand that and exactly how bad any damage may be. In addition, of course, a head and neck exam, the head, ears, eyes, nose, and throat, localizing it, looking for signs of problems with the head and neck. And again, in any sort of dangerous situation where the patient may be unstable, we need to look for other signs of systemic disease that may be causing a headache. And that includes heart exam, lung exam, and skin exam, looking for abnormalities such as systemic infection or trauma, some things along this line that could lead to another focusing down of our differential. So we'll move on to our neurologic exam. Here it is in front of you. As you can see, the patient, for his mental status, is oriented, alert, sluggish, oriented to person and place. That's ×2. He is unable to recall the events that occurred earlier in the day, and he's unable to tell you the date, which is unusual according to his family. Cranial nerves appear to be intact. The pupils are equal. Vision, you do note a slight left upper and left lower extremity weakness, a 4 out of 5 strength, whereas the right is normal, which has caused him to be unsteady on his feet when he had tried to ambulate. Sensation appears to be intact. His visual fields appear to be intact, but he is light sensitive with photophobia. and his speech is slow, slightly slurred, and his GCS, again, at this point is 14. And all of those items that are highlighted there are considered to be abnormal and dangerous. As to the head, ears, eyes, nose, throat, and neck evaluation, inspection's normal. Palpation, range of motion, we do evaluate the patient's head and neck, and we do note that the patient has neck stiffness and inability to move his head in a fluid fashion. He has rigidity. And by rigidity, we mean nuchal rigidity. And nuchal rigidity is resistance to flexion of the neck due to irritation of the meninges. If the covering of the brain is irritated or inflamed, either by infection or blood or some other sort of irritant, any sort of movement of the head and neck will cause movement of the meninges and severe pain. Nuchal rigidity is involuntary. It's analogous to involuntary guarding or of the abdominal exam with an acute abdominal infection. So it is a quite dangerous sign. Now there's two different traditional signs we look for to confirm nuchal rigidity. It's the Kernig and Brudzinski signs. The Brudzinski sign, as you can see in the slide, involves bending the patient's neck, flexing the patient's neck. With that bend, you put some traction on the meninges, causing some stretch, and the patient will involuntarily bend the knees in an attempt to alleviate some of that tension. So it's a spontaneous knee and hip flexion, and that's what we call a positive Brudzinski sign. The other sign that's important to note is the Kernig sign. Essentially, it's testing the same function. You have someone lay down, bend their knee, and you attempt to straighten their leg. Again, this puts tension on the meninges that connect the brain and spine, and the patient will have involuntary resistance to that motion, which again is what we call positive. Now again, these are dangerous signs. They are not 100% sensitive or 100% specific. You can have many reasons to have some neck stiffness or limited mobility, so you can't rely on them. But if they are present, they certainly should raise alarm bells, and they are considered dangerous red flags. The remaining exam is pretty unremarkable. Heart and lungs are normal. The skin is normal. You don't notice any trauma on the skin. You don't notice any dangerous rashes that might indicate some sort of infection or allergic reaction. So we've come to the end of our targeted history and physical examination, and I just want to take a moment at this time to summarize the case before we go into our differential. We have a 67-year-old male, history of hypertension and diabetes, acute onset, worst headache of life associated with physical activity, and so far we have symptoms that include nausea, vomiting, photophobia. We've noticed left-sided weakness, altered mental status, confusion, and neck stiffness. We're going to note that the patient did have a positive Kernig and Brudzinski signs, and the patient has nuchal rigidity. Again, the patient has GCS of 14, glucose of 207, and an elevated blood pressure. So start thinking about the differential at this point. Again, you have headaches are difficult. There's lots of things that can cause headaches. Most headaches are benign, but there's certain dangerous headaches out there, and the dangerous ones can injure the brain. So even though they're uncommon, if you miss them, it's potentially devastating. So there's multiple potential causes of headaches from the outside in: skin, muscle, skull, the meninges, dura surrounding the brain itself. You have blood vessels, sinuses that can cause pain. You have problems with the cerebrospinal fluid and problems with the nerves. All of these can cause headaches. Again, you have your primary headaches, which are considered benign: migraine headaches, tension headaches, cluster headaches. And again, they all can be severe. They can be the worst headache of your life. Everyone's entitled to a worst headache of their life. They can cause neck stiffness, especially with tension headaches. They can cause vision changes, photophobia. They can cause abnormal vital signs, elevated blood pressure due to the severity of the pain. But we're also worried about these secondary headaches, these potential causes. So while migraine headache I would put in the differential for this gentleman given his presentation, we certainly have to look at these other secondary headaches to kind of look for more dangerous etiologies. And at this point, given his history of a witnessed atraumatic severe headache with nausea, vomiting, and what we in the symptoms and physical exam as we described before, I am most concerned about infectious etiologies in this patient, vascular problems including hemorrhage, stroke, or thrombosis, and evolution and progression of a mass that has finally caused symptoms in this patient. Again, while the other ones are certainly possible, without exposures, injuries, or history that's concerning, we can definitely narrow down this differential. Now, in summary, I just want to make sure that we go over once more. Headaches are common. Benign and dangerous headaches can have similar symptoms, and often it's hard to identify which ones are dangerous, but a good history of physical examination can identify the patients that are at high risk and in need of further evaluation. And we'll proceed with more working up our differential in our next talk.